Good afternoon, everyone. We will go ahead and call the Quality and Patient Safety Committee meeting to order. We have a quorum with Ralph. You're here as the alternate for Dustin, okay? All right. We do not have any citizens wishing to address the committee. So our next item will be approval of the minutes. So are there any corrections to the minutes? If there are no corrections, I'll entertain a motion for approval.
I move to approve.
Right. It's been moved and second for approval of the minutes. All those in favor signify by saying aye. 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 And then nay. There are no nays, so motion approved unanimous. We will move right into our quality patient safety reports and updates, not requiring committee action. So, Dr. Banamosa, would you please come up and start with patient voice?
Good afternoon.
Afternoon.
For the patient story today, it's really about a very important program that we have here at JPS. For most people, leaving the hospital means going home or going to other care facilities to regain rest and to get some rest and regain strength. For patients that are experiencing housing instability, going home is not an option, and going to another facility, especially if unfunded, is not an option. And recovery becomes far harder than it should be. The JPS Health Network Cooperative Care Program was built to close that gap. It has been recently reorganized and under the integrated clinical care model of medical respite care. And it meets national standards for coordinated compassionate care, working along community partners such as the Presbyterian Night Shelter and the Salvation Army. JPS provides patients a safe bed, a dedicated care team of provider and a nurse who deliver hands-on care in a setting designed for healing. The patient receives a clinical assessment, personalized care plan, and chronic condition management and coordinated follow-up. One of such patients, Tony Jemison, knows the difference this makes. After multiple hospitalizations, surgeries, and the loss of stable housing, Tony faced recovery from serious medical condition with nowhere to rest or recover. As he puts it, being in the hospital takes a lot out of you. When you don't have a home, you don't have a place to rest, how do you get your strength back? Through this program, Tony was given a place to stay and a team committed to his recovery. With regular wound care, medication support, and guidance managing his diabetes, he began healing both physically, emotionally, and psychologically. Tony said, "I will be in a lot worse shape without this program, and they've helped me overcome things that I didn't think I could." That support also strengthens outcomes in our community. With a provider available and frequent nursing checks-in, concerns are caught early, which reduces emergency room visits and prevents readmission. Jill Stafford, the practice manager at JPS Medical Home True Worth, described it as a model built on patient care and connection. She said, "Healing doesn't happen overnight, and it's nearly impossible without a safe, stable environment. It takes a strong partnership to make something like this work, and our community partners are essential to that success." For patients like Tony, a place to recover can change everything. His advice to others reflects the trust in this program earns every day. Listen to the people here at JPS, he says. They know what they are doing. Use the help. It is there for you. Thank you very much. I think this program is fantastic, and as I really had an opportunity to speak to the people running the program, it's really one of those bright spots that addresses unique patient situation. And it's literally a win-win in collaboration with our community care partners, frees up bed space, ensure that patient gets a place to recover, reduces ER visits, and they get all of the care they want, where they can recover until they are back on their feet. Thank you.
That's a standard, that's just one of the programs we have working with our partners.
Yes, ma'am.
Oh, okay.
Yes, ma'am.
Do we have a lot of patients that we have to go through this program?
We do, and based on the census and the data that I actually have reviewed, we do have, at the Presbyterian Night Shelter, there are 10 male beds and 2 female beds, and at the Salvation Army, there are 2 female beds. And the average census looks like about number of admissions 17,
Great.
referrals 23.
Oh.
Patients stay there for a while, and so, really, quite impressively, the 30-day readmission rate for this group of patients is extremely low.
All right.
Mostly 0 to 1 people come back to the hospital every month. Yes.
All right.
That's excellent.
That's great.
So when a person stays at these two facilities, are they there, how long?
So the average length of stay is about 2 weeks, 21 days, between 2 to 3 weeks, rather. On some days, like in May, it was 13.7 days. In February, it was 22 days. So,
Dr. Radamos, you want to just mention kind of what are those diagnoses that often are cared for?
yes, especially wound care,
care is a big one.
diabetes, and especially on a lot of our surgery, post-surgery patient that get admitted there. So they are the patient with multiple medical comorbidities that really, and they don't have a place to go. These patients are actually still able to perform certain activities of daily livings by themselves, but they do need some help and support with managing their wound that they are unable to do by themselves, as well as check their blood glucose, administer antibiotics to ensure that all of those are under control and they do not develop any complication.
So do JPS employees go to
Yes,
Salvation Army and
yes,
they're in that shelter daily, check on them?
yes, sir.
Did we have a number for hospital days or something that we actually, I thought we had a number, maybe I'm dreaming on that, of how many hospital days we actually were able to.
Yes, I think we're actually collating that data, and
Great.
we'll put it all together and bring it to the board to share.
Wow, that's great. All right. Thank you. So I know you're going to be with us a long time, so next you're the sepsis program, so.
Yes, ma'am. It's really my pleasure to present the sepsis program to the board, and this is a program that is really near and dear to my heart, but it always comes better from the people that actually do the work. So it's my pleasure to invite Malika Qureshi. She's our clinical sepsis coordinator. Jessica is also sitting with her. She's our clinical sepsis nurse. And Dr. Jocelyn Z, a co-intensivist like myself that has been with the program from the beginning. And she probably wouldn't want me to say this, but today is her birthday.
Come on down.
And she's on PTO, but because of how near and dear this program is to her, she actually came by to help talk about it.
For decorum's sake.
Dr. Johnson unfortunately could not be here today. He's post-call from the emergency room.
Okay.
All right, I will turn it over to Dr. Z and Malika.
Alrighty, so I'm going to start us off just with a little bit of background. I think I do know some of you here in the room, but I think sepsis doesn't, in my opinion, get as much recognition necessarily as like stroke or heart attack. And so in the community, I think there may be some misconception to what sepsis actually means. What starts out as a simple infection, something like a pneumonia or urinary tract infection, actually can wreak havoc on the body. And I think an example that I recently heard, an analogy that might be utilized for our patient education to make sure that we recognize sepsis as being something that is potentially very life-threatening is a fire breaking out in a multi-story building, and maybe in one room. And so the sprinkler system is supposed to recognize a fire and just take care of it. But if the sprinkler system in the entire building goes off, then we're dealing with flooded rooms and the electricity going out and everything just kind of collapsing, and all of the inhabitants have to vacate the building. So that's the immune system. It's a abnormal response to a local infection. And so what we're showing here is really just the spectrum of what the disease could happen, and because our patients have so many comorbid conditions, it really puts them at high risk for developing severe sepsis or septic shock. And I think, you know, I've been at JPS for quite a while, all through my training, and have been here since the inception of the sepsis program. So it's really, really neat to see that we've gone through 4 cycles of recertification, and we are the first public hospital to be disease certified by the Joint Commission. So I think that's a very proud thing that we have to stand on top of being certified in, you know, heart attack and stroke and the others. And we've just recently gone through our 4th recertification just last month. And Malika's been with us less than a year, and she's carried us through that really quite amazingly. And so I think we have a lot of our sights on a lot more higher accolades, but mostly just, again, to bring it back to the community so that they recognize, and you'll see that in kind of our later slides, about the educational component of this and how we try to take care of our patients here.
Dr. Z. And thank y'all for taking the time to hear about this program. It is absolutely near and dear to my heart. Not because I like sepsis, I don't like sepsis at all, but because of how important it is, and you know how Dr. Z explained it as a burning building. It really is, and we'll get into that. One thing that I did want to mention that is really exceptional is JPS was the first public hospital in this country to receive disease-specific certification in sepsis, and so that's a pretty big deal and something that, you know, yeah.
Congratulations.
Thank you. So that was well before my sepsis knowledge. But I'd like to take a moment to really talk about why this program matters. So we know why sepsis matters, but why does this program matter? Sepsis is one disease process, but really it has a uniquely broad impact. And so from an outcomes perspective, we're talking, it is a significant contributor to our patient mortality, their readmission rates, the cost of care, and really patient safety. And so from that aspect, it's absolutely something that we should look at. But there's also and a lot of the staff probably wouldn't speak to this because it's not their level, but there is a huge financial as well as reputable component to sepsis care. And so it's tied into our hospital-based values purchasing program. And so that in turn means that the quality of care that we provide impacts our reimbursement rates. And so that's important. It's also publicly reported, which means that it impacts our CMS star rating. And so that's our reputation. And so now sepsis has moved from just being a clinical priority to also being an organizational priority. Now, the quality of care that our surveyor recognized isn't something that happened overnight, and it's certainly not due to one intervention or one person. It is absolutely an indicator of the multidisciplinary collaboration, the nurses, the pharmacy, lab, we're talking the board support, leadership, their engagement. Ultimately, regardless of which discipline the team member is or their subject matter expert, there's one thing that we all hold in common, and that's we're here for the patient. And so one thing that in my short time at JPS I've come to love is that our patient isn't our priority. Because let's be honest, priorities shift based on whatever circumstances changing. Here at JPS I've noticed that our patient is our value. It is literally ingrained in everything that we do. And so it makes it easy. So whenever there are any discrepancies from the disciplines, we all remember that we're here for the patient. And so this collaboration happens daily, absolutely. But in addition to that, we get together every month and we talk about our performance. And it's not in silo. We look at opportunities and how we can support each other. And ultimately that support translates into supporting patient care and their outcomes. And so multiple disciplines, one purpose, right? That structure is it's not an informal structure that leads to quality. I'm sure y'all are very familiar with this chart, but it is formally integrated into our quality reporting structure. And so sepsis reports up through our Unified QAPI plan, through the JPS Health Network Quality and Safety Council, and that gives us a level of accountability. And so we speak to our metrics regularly, and we look at that. But in my opinion, even more important is what translates down. And what that is it is building our resilience. It is ensuring that our efforts are tied to that strategic goal. And it means that as our patient population shifts, as their needs shift, we've got that resilience to be able to meet that, and that our efforts are not silo efforts and just strengthen numbers. Speaking of numbers, why that infrastructure is so important. When we first started looking at sepsis care, and we, meaning JPS, we saw a little less than 1,000 patients a year, okay? Today, we see over 2,500 cases a year. That's more than 2.5 times the patients. And our patients are sick, let's be honest. Our patient population is not the typical patient population. As a safety net hospital, we see some sick individuals. And so it's really important that, you know, our care isn't just checking boxes on a list, that really we've built a system, a reliable system to make sure that every patient, every time, we're addressing those needs. And so the scope of our program has really grown to meet that patient demand. So when I say meet that demand, meet the need, how do we perform with that increasing needs of our population? And so that takes me to that federally mandated metric that I briefly spoke on earlier, SEP1. SEP1 is a CMS metric based on evidence-based practice. It says this is what is best for sepsis care for patients with severe sepsis and septic shock. It is a very strict method. And when I say strict, I mean it's all or nothing. So every single element needs to be done, and it needs to be documented, and it needs to happen in a very clear time frame. So we can do everything right. We can do it in absolutely the right time frame. But if we haven't documented it correct, we, quote, fail, okay? And like I said, that's publicly reported. So, and tied to our reimbursement. So how do we make sure that we're giving that high quality care, keeping record of it, and ultimately giving our patient the best chance? So increasing volume, strict metric. The question is, how does JPS perform on that strict metric? This warms my heart to show y'all. So the dark blue is us, and you can see in 2023, we were performing at roughly 73% compliance. 2024, we bumped that up, 81%. Last year, we were sitting at about 86%, okay? The national, just to give you a sort of comparison, state level and national level, we're looking at low to mid 60s. That means our care is 20-something points higher than the national level. And even more impressive is the trajectory. So we didn't stop and say, we're the best. Good enough is good enough. Absolutely not, because we understand that our goal was never a metric. Our goal was always the patient. So we took it a step further and a step further, and we will continue to do so because it's the right thing to do ultimately, not because it affects our payment, not because it's publicly reported, but because, again, our patient is our value.
Let me just ask a question here.
Absolutely.
What were some of the things that we're doing maybe that other places aren't doing that has allowed our compliance to be so high? Dr. Z, you may want to speak to some of the.
So year over year, I think the 100% manual abstraction that the team was doing, so every single severe sepsis septic shock case was looked at. And in real time, of course, with the development of Epic and Epic chatting, we would actually real time message either the nurses or the visitors like, could you document why? And, the physicians historically are just kind of like, let me do my thing, I think we got people on board. The stakeholders were like, this is important. Thank you for reaching out. Of course, we're a teaching hospital, so lots of opportunity for learners to say, oh, I see, thank you for doing that. Or recognizing when something maybe wasn't sepsis and how they can feed that into the note so it makes sense. Or there are certain exceptions that if someone is on palliative care that we discovered because the team was like, these are all the exceptions in wording. Really, everybody says words matter, in your notes especially, so that at the front line, the nurses knew, oh, I see why it's important to draw this lactate. I see why it's important to get these blood cultures before antibiotics. And it was so granular for so many years, and I think that's really kind of like, either they're like, we're tired of these messages, or no, this makes sense, and this really, you really see it and reflected in the
Yeah,
statistics, so.
I think you make such an excellent point. If it doesn't make sense as to why we're doing what we're doing, if it doesn't impact the patient or allow you to get to that patient earlier in order to intervene, so I think that's always the hardest part, but once you turn that corner, then I think the compliance starts to improve.
I don't think this slide deck necessarily has all like the granular, every single metric or the data points, but across the board, you can see improvements in mortality, lengths of stays, all of that, because just by this one metric alone.
Wow.
So, thank you.
And I'm really glad you said that, Dr. Z, because that is actually my next slide. So what does that care mean? Okay, ultimately, we said our patient's our goal. So I'll admit, when I looked at the data and I put together this first graph, the bar graphs with the 3 different shades of blue, it looked the same to me. But what I don't have in there is the actual numbers. So that light blue section, if you look ever so closely, it increases. It goes from 46 to 55%. But Malika, what is that light blue? That is the early stages of sepsis. We are catching it early. We are seeing more and more cases that fall in that light blue category and don't progress into the darker blue or the darkest blue. The darkest blue is going to be the far end of that spectrum, those patients in septic shock. And so we have decreased 26 to 19%. So that's a pretty substantial shift in severity of sepsis that we're seeing. And what does that mean in terms of outcomes? Our average length of stay is down 27%. And that's just from 2022. I'm not talking 2012, 2013 when we started, just in a 3.5-year gap. Our 30-day readmission rate from the time period shown is at an all-time low. Our mortality rate, my favorite, we're down to 6.5%. So that is really a reflection of a system that we have built. Yeah, absolutely exciting work. And so recognizing that the patient is the goal means that the goal doesn't begin and end at our hospital doors, okay? Our sepsis program has to go beyond hospital walls. So what does that mean, Malika? It means community awareness, but it also means community education, and those are very different things. It's one thing to say, oh yeah, I know sepsis is a thing. It's another thing to say, my loved one just had an infection, my loved one is at risk of sepsis, this is what I need to look for, and if this happens, this is what I need to do. Very different messages. Unfortunately, most of our nation, they don't even know what sepsis is. They may say, oh yeah, wasn't there a race car driver that had that? And that's the extent of it, and it's sad. And so we get out there and we talk about awareness, we educate the staff, we are looking at how to strengthen our screening and prevention. And honestly, regional leaders, we don't just share our learnings with our patients and our clinics, we speak at conferences. So the DFW Hospital Council has a conference every year on sepsis, and JPS has been absolutely vital to the success of that conference, from the logistical planning of it to even speaking. This year, we have 2, maybe 3 speakers from JPS going, and I won't say any names. But there's a lot more on the horizon. We're also involved with Texas AIM, which is focused on advancing innovation in maternal health. And from what I understand, maternal health is an organizational priority. And so sepsis really sits at an important intersection of JPS priorities. And that being said, I wanted to throw in a slide with pictures because it's different. Looking at numbers is important, but looking at the actual faces, that's touching to me. And so this is just an example of some of the events that we've attended. And you can see in that really long horizontal picture, the sepsis conference, I believe we had 2,800 attendees there from hospitals all over the Metroplex. And this year, we're expecting even more. Don't tell Dr. Z, but the hall can hold up to 5,000 people. And one of the speakers is actually going to be our very own Dr. Lopez from Women's Services. So we will be sharing our efforts in maternal sepsis. So a little more about maternal sepsis, because it is a very special population. And why? So the body's response to pregnancy often masks early signs and symptoms of sepsis. And so we miss it in that population, we being providers and nurses. We miss the changes that we would normally see in a non-pregnant patient to catch sepsis early. And so the nation, and this is per our surveyor as well as the literature, our nation really has not acknowledged the burden of maternal sepsis, just how big the problem is. Not only have we acknowledged that maternal sepsis is a thing, we actively look for it. The maternal team and the sepsis team got together to really bridge that gap in screening tools, as well as protocols and clinical practice guidelines. And we collaborated to make sure that we are setting our teams up for success, that we're setting our patients up for success. And at our survey, the sepsis surveyor, Anne, she commended us very, very highly. I get goosebumps just thinking about it. And she really urged us, almost begged us to publish what we're doing, to share our findings, and to set an example for our country. Yet again, step up to the leadership plate, not that we ever left it. And so there is a lot of exciting, innovative work that we're doing that's saving moms' lives and letting them go home to their kids and really shaping the future. And so we are looking at the future direction of our program and how we're going to share those findings. And because we have a responsibility, not just to our moms, but moms across the country. And so, yeah, kudos to the maternal team and Dr. Z and everyone for what they've been doing. As a mature program, the opportunities become a little harder to find. And so taking it to the next level is what we hope to do in the future. And I hope that the next time that I get to present to you, I'll be able to share more exciting things that we do. Can I answer?
Jessica?
Yeah.
Anything that you want to add?
Well, I just feel like there are a couple of important statistics that I know that you were going to speak to, so you may be getting to that. But I just want to remind everyone that also every hour that we delay antibiotics, that risk of mortality for our patients goes up by 8%, right? And per our CMS bundle, we actually have 3 hours to get that first antibiotic started, but that's not good enough for us. And we look at 60 minutes, and our providers and our nurses, they do outstanding job at that. And then the other statistic is that 85% of our patients, they come to us with sepsis. So they're coming
It's
to us and
actually
they're
up to 95%.
95% now. So they're coming to us with that light blue, right, on that graph, with simple sepsis is what we would call that. And just like Dr. Z presented, it's a cascade. It can be a cascade of events and eventually get to septic shock, but it just shows that we're recognizing it very early and we're stopping that cascade. So I'd just like to share those two statistics. And I'm excited to be a part of this team for sure.
You have something you want to say, Blake?
Questions. I appreciate the presentation, and I'm not a medical person, so some of these may seem obvious to you. First, just a statistical question. Our average length of stay dropped from 13 back in 2022 to 10 days now. Is that measured from the date of admission or the date that we diagnosed the sepsis?
Date of admission.
So they may be here a week before we even know.
So typically,
Typically,
what we've seen, and that 95% of our patients are coming in with sepsis present on admission. So only 5% of our roughly 200 patients a month are developing sepsis while they're here.
Great.
how do you know that they have sepsis? Can you test for that?
That's a great, no, That's a great question. Unlike heart attack or stroke, there is no definitive test that says, hey, this patient's septic, which is what makes it even harder for us. But our team is so good and they care so much that if there is even concern for sepsis, we're initiating that bundle. And then we have time. So we stabilize the patient in the ER, and then we have time to rule out or rule in whether or not it is sepsis. And so my data is based on, at the time of discharge, did we deem that they were septic?
How do you know if they brought it in or if they acquired it in the hospital? How do you tell?
So on admission in the emergency department, when they're triaging, it's a set of vital signs that meet certain markers, plus a suspected source of infection, whether it's something on the skin, in their lungs, in their abdomen, even in their brain. There's also surgical sepsis potentially because we've made incisions into the skin. And so based on the patient's history and constellation of symptoms and any objective markers, laboratory findings and vital signs, that all goes into when they're triaged. When the patient's already in the hospital, sometimes they're here for something else entirely. We actually have early warning systems in place in Epic that will actually flag everybody. It's like, oh, there's been a change in vital signs. Did you consider, do you think there's a new source of sepsis? And so the nurse is actually very programmed into looking at that as well, and then notifying a physician if like, oh, I noticed there was a spike in temperature, and then that person will then see if it's appropriate to initiate the bundle while they're in-house. And so you have those two buckets of people, the people that are present on admission and the people that are already here.
I was gonna ask you if there's something we can do to reduce the occurrences of sepsis, but 95% are walking in the door already. It's
It's-
not the 5% less is working. Well, what, with the 5% left, are there things we can do to reduce that so that it doesn't even happen?
Yeah, and I think some of the things that happen, which is part of kind of other preventative strategies, so before they hit the door, the 95%, because that is the bigger number, is the community education. Like if you do have a rash or you feel like you're sick, go see somebody sooner, et cetera. And what are the signs of family members noticing somebody that like, oh, I think I need to bring them earlier. So we do want the light blue to be bigger because we don't want the dark blues. When the patients that are already here, it's the same thing. Hand hygiene, I think, will be like something that I feel like maybe we've heard quite a bit. It starts with those simple things, wound care. There's kind of, it depends on how or why someone develops sepsis while they're here. To getting central lines out as soon as possible, getting Foley's out as soon as possible, not being hooked up to a mechanical ventilator. So I think we kind of, again, getting those opportunities since we're doing so well. I mean, I say 100% and 0%, right? So there's always opportunities for improvement to determine what is that 5% made up of? Is it post-operative? Is it completely here for nothing at all? And so that's where we kind of need to look more granularly at each individual case to see where the opportunities are.
Plus, a lot of our patients have comorbidities that predispose them also.
Yeah.
On your community education, I know I get a newsletter every now and then from the hospital district. Is any information added to that, kind of start educating the public on what to look for? That would be a good way
I
for
like that.
us to start
think there is.
getting that out, because I am interested in the community education, because the more we educate they will, to help them, since 95% are coming in, that would be something critical.
I think much like we do with stroke, I think there's,
We need to come up with a
The
new one,
warning
like,
sign,
be fast,
yeah.
except
We
for
actually have
sepsis.
one, time, yeah.
I think that would be great.
The ER came out, trauma team gave something that you could put on your refrigerator that give you the signs and symptoms of stroke and kind of heart. So if y'all had something like that, that would be great.
Yeah,
Okay.
Jessica
Well,
actually
wonderful
developed that,
presentation.
so, yeah, thank you so much.
You want
Time.
Time.
It's kind of.
Oh, yeah, it's,
how to identify sepsis, temperature, infection, mental decline, extremely.
Time, yeah.
so those are fridge magnets that we have, and we're actually getting them made in other languages, too.
Well, I'm very glad to see the maternal sepsis, because we've been doing everything to reduce that and mortality for women, so great on that one. Excellent. Thank you for a wonderful presentation.
Thank you.
Okay. Anyone else have any questions, comments? Okay, great job.
Thank you.
All right. Now, quality priorities, okay.
Yes. Thank you all again, Dr. Z and Malika, for all of the work that you do, and Jessica and Dr. Johnson. You all do a fantastic job with our sepsis program. All right. For this month, I'm bringing back 2 strategic quality priorities out of the board's strategic priorities for FY26, and we'll be talking about patient experience and the Africa program. For the patient experience, we're actually doing quite well across board, and our number continues to improve. And really, this is as a result of a lot of ongoing work by the patient experience team. They have been very focused and intentional across all of our services. This time around, in my conversation with George, our VP of Patient Experience, one of the areas they're actually focusing on is the inpatient side, where we do have some opportunities to improve experience in view of all of the very high volumes of hospitalization and admissions that we're seeing. They have proactive issue resolution by sending patient experience team members to round on the inpatient units and to ensure that any complaints are resolved preemptively, and also to collaborate with the nursing team on the inpatient units to ensure that all of these issues are appropriately escalated and resolved. In addition to that, some of the interventions have really resulted in the improving numbers that we're seeing in terms of patient experience is clinician engagement and coaching. They have been breaking down our data and providing those feedback directly to each individual physician. This is what your patient are saying. Not only that, they also offer coaching services. Okay, this is what to say. This is how to say it. These are the things to look for. And they've also been visiting with clinicians while the patient is in there to actually observe and provide actionable feedback. This has also been coupled with recognition, where people are doing well and really recognizing and rewarding top-performing clinicians. They recently rolled out an award for, they call it top 1%, for people really achieving in the top 1% of patient score, and even by nomination of exemplary patient experience intervention. Dr. Z that I just presented was one of those top 1% awardees for exemplary patient care and experience. The next program is Africa. As you all would know, this is a quality program mandated by the state of Texas that looks at the quality of care provided to Medicaid patients. And there are a lot of components to it, and it is undergoing significant reorganization that the state is going to finalize, I think, sometime in September. There's a meeting coming up next month. But it does have 6 metrics that we have been following that cut across some of the board's priorities as well. You can see cesarean section, maternal health, readmission, post-op sepsis, one of those sepsis syndrome that develops in the hospital, food insecurity, immunization, and safe opioid use. We continue to do well on all of the measures at this time based on the benchmark established by the states. And as I mentioned, it will undergo significant change in short order, and they are making some changes to the metrics. And mid-year, I think last month actually, they made an announcement that they are removing the immunization component for flu shot. That is no longer part of the Africa program. So that's why you can see it crossed out.
Goodness.
So these are the 6 metrics on your slide.
Yes, sir. These are the 6 metrics.
Now there'll be 5.
Now there will be 5. Yes, that is correct.
Okay.
Well, the Africa Action Program, I mentioned earlier that this really focuses on Medicaid patients, but what are we doing and how have we sustained our performance with Africa? We apply all lessons learned to all patients, regardless of payer. Our interventions are payer agnostic. If it's good for Medicaid patients, we do the same intervention for all patients, regardless of payers. We continue to work with our maternal care team to look at our cesarean section rates for opportunities, and we'll provide them with transparent data for peer comparison. A lot of our intervention, you will see progressive increase in those for food insecurity, discharge hard stop for opioid prescription at discharge. to ensure that patients are not getting multiple opiate prescription. All of those are hardwired. Even when they stop being a metric, they will still continue to be there to ensure that patients are still benefiting from that. And in addition to all of the other measures, metrics, and reports from the department, committees, and programs that I'll be presenting, we also have a strategic quality scorecard. The section that affects quality in the strategic quality scorecard is the clinical quality composite. And this is our achievement so far. Again, you will see NTS's cesarean section rate is featured there prominently. We are having full achievement with that. 30 days all-cause readmission, PSI 90 composite, and control of blood pressure, where we're achieving full 3 points. This data is through May. There are some lagging data that once we get, we'll update the scorecard. Our current achievement is at threshold with a total point of 6. There are multidisciplinary teams that's actually working on all of these. You'll see the maternal program. This, our strategic quality scorecard, really carries cesarean section as well. Africa is cesarean section, so there's a neat crosswalk across that. And we, all of our intervention are geared and are the same for both programs since we're applying it across all patients regardless of payer. We also have daily safety bundle that we have successfully deployed across the organization that ensure that every patient, every day, will look at hospital-acquired infection, we look at pressure injuries, we look at fall. The goal and commitment is zero harm and to really improve clinical ambulation every day. Hypertension and discharge safety, as you probably will be aware, there are about 72 residential zip codes in Tarrant County. And in all of those zip codes, patients that come to JPS from all of those zip codes, the number one diagnosis or comorbid condition is hypertension. The community prevalence of hypertension in Tarrant County is the number one comorbidity in Tarrant County, which is why, looking at that data from the community, we are really focused on controlling blood pressure. The downstream consequence of hypertension is heart failure, stroke, kidney disease, and if we control it early, we can actually change the trajectory of a lot of these patients. So what we have done is we do have some heart stop alerts to ensure patients going to our primary care clinics with uncontrolled blood pressure are flagged before they leave, and an opportunity for the clinician to really intervene prior to they being discharged from the clinic.
Dr. Bendemosi, is
Yes,
this
sir.
clinical quality composite part of Africa, or is it an independent?
It is an independent. It is part of the strategic scorecard. That is the name for what used to be AIP.
And is this a JPS initiative? Or
Yes,
is this
yes.
state or federal?
No, this is JPS
All
initiative.
JPS.
Yes, sir.
This is on top of whatever
Absolutely, yes,
we would say.
yes. The next section is a quality dashboard. In addition to every single quality metrics that we present, we do track a lot of quality metrics, each with its own action plan. It's across 7 domains, and there are 32 quality measures that we track. We are currently evaluating all of these measures. There are some that, a lot of which we are doing well in, and we will be coming up with some proposed replacement for some of these measures. All of the measures are tracking as expected, and where they are not tracking in the right direction, we have appropriate action plan to support those. The next section is the QAPI plan. QAPI plan is mandated by CMS and is a condition of participation for both Joint Commission and CMS, and this is where we bring reports, just like the one we've listened to from programs, from other departments, and from committees that has quality to give us an opportunity for quality assessment and performance improvement. So for this quarter, will be the presentation from anesthesia department and women and infants, and for June, Life Gift Cancer Committee and Critical Care, and for July, respiratory therapy, radiology, and trauma. We will be presenting this in summary fashion. So for anesthesia, I think the role of the anesthesia department is very clear. They cut across a lot of our procedural areas to make it go smoothly. They affect throughput, they affect surgical outcomes, as well as maternal health for epidurals during labor. And the performance, in summary, by the anesthesia department is strong across all of their measures. The metrics that we are reporting for anesthesia this quarter is patient experience and unplanned admission or transfer due to anesthesia complication. This really reflects outpatient procedures, surgery cancellation on the day of surgery, and labor epidural consult response in a timely fashion. They are doing very well. Occasionally, they do have 1 or 2 patients that will get admitted to the hospital after an outpatient procedure, usually for minor issues. And when this happens, each and every one of those undergo a review and with resolution. The next department is women's and infant. JPS is a maternal level of care, level 4, as designated by the state of Texas. And they continue to take care of any level of maternal care. They provide any level of maternal care. And excitingly, Dr. Carson Anderson and the Women's Department are really collaborating with the North Texas Maternal Health Accelerator, which is a regional coalition that really the sole aim is to drive a 20% reduction in severe maternal morbidity and mortality. The strategies they are approaching, and they've been showing early results, and I met with them and they did share some of the data across the community with us. It's iron supplementation to really ensure that pregnant patients have blood buildup in case they bleed during delivery, coding standardization to ensure we all speak the same language in describing maternal morbidity, and we can compare our data as a result of that. Also, maternal health hypertension to ensure that that has been controlled and managed aggressively, and population health analytics. This really helps point a direction on where we should be intervening. Where are the sickest patients coming from? What conditions are these mothers having, and how do we deploy resources to those areas? So JPS is really a founding partner in this intervention, in this coalition, and the early data that we are seeing is actually looking good. It's a multi-year process. All of the area hospitals have also joined this coalition, all geared towards reducing severe maternal morbidity.
And we think this will continue to be funded.
We think so. The initial seed money that was produced through a conglomerate in the community has now been matched by federal dollars, and the anticipation is if the result holds and they achieve the target, the federal dollars is going to continue. And so far, the early data looks good, and they're on track to actually get all of those matching dollars. These are some of the metrics for the women's department that they are tracking. Our women's department, they are doing very, very well. And a few of the metrics, or a couple of the metrics that is the postpartum follow-up appointment made within 3 days for severe hypertension. Their initial goal for this metric was 50%, but they have blown past that. The average of 68% that you're seeing actually does not show that the number has steadily grown. And at the last reporting for this presentation, it was 81%, and they have surpassed that now. This is something, a challenge they actually really self-develop, and they are tracking by themselves. They also, one of the more severe maternal complication is actually bleeding during delivery, which is what placenta accreta spectrum disorder really targets. It's one of the major causes of maternal morbidity and mortality. And the program here is very, very robust. For several years, I was co-chair of the maternal fetal medicine and ICU committee that actually looks at this specific disorder. And it's been a fantastic, well-developed, well-run program that meets frequently to evaluate every single patient and create a comprehensive plan of care for those. So that is really one of those programs that really works well. critical care, this is near and dear to my heart as an intensivist. We do have a lot of critical care beds in the ICU, but they are all being used and more. And in JPS, when we say critical care, it's actually a combination of the intensive care and also the progressive critical care beds. And this unit take care of the sickest patient across the hospital. If there's a complication, it's most likely going to happen in the critical care unit. So we really focus on the critical care areas, including the ICU, to ensure that care is optimal, and we are aggressively standardizing our care to really ensure there is minimal variation in care. And these are some of the metrics that that we've been following, and you can see central line bloodstream infection. We are doing very well. And ICU length of stay, CARDIs for, you will notice that with the hospital-acquired pressure injuries, we're seeing a little bit of that. And in a way, it's not a good thing, but it's also explainable. One of the things that we have instituted is really ensuring that we have a 4-eye scan assessment on every patient every day. So we are basically looking a whole lot more than we've ever looked. So across, even in a couple of other presentations, you will see hospital-acquired pressure injury. We expected this when we rolled out a program of the 4-eye scan assessment on every patient. Regardless of stage, we want to capture it, we want to document it. The biggest intervention being we do not want progression, right? And we want timely intervention. So seeing that number is as a direct result of the intervention. The Choosing Wisely bundle, this really is a bundle that we rolled out in the critical care unit, especially in the ICU. And what it basically does is, have you spoken to the patient or the patient family every day? It also contains a question about, do we still need all of these lines and tubes that this patient has? Or should we remove them? Does this patient still need to continue to get antibiotics? Should we continue drawing labs on all of these patients? These are really non-controversial interventions that are meaningful to patients and outcomes. We rolled it out last year, and gradually, we have definitely surpassed the 71.6% average because it started slow, and at the last report, we had 90% for the month that was presented. So this is something that we want to continue. Every patient, every day. We actually optimized it a little bit more to include fall and pressure injury, which you will see, because every day we want there to be, on every patient, what is the risk of fall on this patient? What are we doing? What was the 4-eye scan assessment? What did we identify, and what are we doing in a collaborative way during care rounds?
Dr. Batless,
Yes,
you've got a couple of infections mentioned here on the critical care slide, central line
Yes.
and catheter. Are those generally synonymous with sepsis, or can they lead to sepsis?
Great question. Yes, they can lead to sepsis. These are lines, central lines are big IVs that we put somewhere around the neck, in the bigger veins of the neck. If left in one, if not properly placed in a sterile fashion, we have an insertion bundle. It's a checklist system. You must wash your hand, you must drape the patient, you must clean the area. That is our insertion bundle. Maintenance bundle, every day. The most important part of maintaining a central line is, do we still need it, or can it come out? And what is going through it if we still need it? Do we have any other option? Have we cleaned and have we visually inspected the site of insertion? Does it still look okay? Is it time to change the dressing if we still need to keep the central line? Because if we do not follow those strict checklists, then the likelihood of developing infection becomes elevated. And that can lead to hospital-acquired sepsis, to your earlier question around sepsis developing that is not present on admission. And hospital-acquired sepsis is actually more severe, which is why all of these, the central line bloodstream infection and the Foley catheters, right, we want to reduce or eliminate those if it's not necessary. Only if people cannot really urinate by themselves would they need a catheter. That really is the only indication that we are beginning to push with our clinical colleagues. But you're absolutely right. If we do not take care if we do not take care of those two lines, because we do those procedures, and they can really lead to complication. And the most important complications are those infections.
But if there is an infection, you can treat it before it leads to sepsis.
If there's an infection, we can treat it before it leads to sepsis, and the best treatment is to take them
Just
out.
to remove it.
Yeah. Yeah. Yes, sir. Next is the Cancer Center. The JPS Cancer Center and program is accredited by the Commission on Cancer, COC, that is the primary accreditor of all cancer centers across the United States. And our performance is very, very strong at the Cancer Center, really. And most of the measures meet and exceed COC target for both FY25 and FY24. There are some focused opportunities that I'll be sharing and the reason why those opportunities exist and what we are doing about them. And of course, increasingly we are using the compass rules, which is really a navigation dashboard to really help patients move across all of the treatment milestones. So you will see here in this first portion of this table, we are doing well with cervical cancer, colon cancer surgery, and lung cancer surgery. We are doing well and will continue to sustain our performance. For breast cancer, colon cancer adjuvant chemotherapy, and head and neck cancer radiation, we are not hitting target. And the primary reason when all of this data is analyzed is a lot of patients get their diagnosis established outside of JPS. Then they get referred to JPS for various reasons. And the cancer treatment, given the nature of it, requires that there is verification of imaging, verification of pathology to really ensure, verification of support system, or creating one for them where that does not exist. So this data is reflective of all of those situations that some of these patients come into our cancer center. But with use of compass rules to really see where each patient are, where they are tracking, what is the next step, and that has given our cancer navigators an opportunity to be able to track these patients real time. Life gift. Organ and tissue donation is mandated by the federal government, and it's a CMS condition of participation that we must participate in organ and tissue donation. Again, the key thing to understand about this is it is purely voluntary and it is driven primarily by the individual themselves or their family if the individual has not indicated on their driver's license that they are a registered donor. JPS does not influence any of this. Our role is really a strict protocol that we enforce with tight guardrails that keeps the organ procurement organization separate from clinical decision making. That really is the focus of our intervention. We are doing well based on all that we are required to do in terms of timely referral and collaboration with the OPO. Organ donation rate is not a target that JPS set. This is just a reporting of what our organ procurement organization, in this case LifeGift, the target that they set. And whether or not donation happens is really dependent on family or that specific individual. And we support and we work with them closely, but we have all of the rules that have been established and guardrails that we observe. Respiratory therapy, their primary focus is in the ICU and the critical care areas. They help manage ventilators, breathing treatment, and lung testing across both in the hospital and in the outpatient clinics. They are doing well, and we are actually working with them in overhauling their metrics that will be reported just based on how well they have been doing. All of our ventilator-related metrics are doing well. The turnaround time for arterial blood gas that we use in critical care we are doing very, very well in those as well. One of the areas of focus, again, related to my comment earlier about our intensified focus on pressure injury, is we are finding a lot of it. And we are developing action plan, and we anticipate that the numbers are going to start going down, and the rate of progression should also go down. And there's another interesting thing I would like to draw attention to. We don't use ventilators even in critical care as much as we used to do, just because the mask ventilator are so efficient now and almost as good as ventilator and much more convenient for the patient. But that comes at a price, because if we're using those masks and the high flow nasal cannula, we use them for longer, and they tend to cause pressure around here. And if we take them off, oxygen level could drop, which means we really have to be careful and monitor every day for any signs of pressure injury, which is why that is an ongoing area of focus for us.
It's always the bridge of the nose, it's nowhere else.
Yes, it has to be kind of like over the nose and the mouth. There's some masks that are just over the nose, but the one that we prefer is the full mask.
It's kind of cold.
Yes, sir,
An
absolutely.
injury.
That's really one of the conditions.
Is there anything we could put between where the mask hits? And I mean, how are other organizations dealing with? Because I agree with you, this kind of better way of providing.
Correct. So we do have some gel-like material that is soft
the
that we
skin from
use to
breaking.
pad, yes, as a barrier. But again, there is a requirement for the mask to be effective for it to fit well.
Yeah.
So that is really the tension and the balance. But we do believe that with adequate attention, daily evaluation, I think once we become aware of it and are intentional about it, we can actually mitigate some of this. Switching between devices also is strategy where appropriate. If we use face mask for a while, maybe overnight, by the morning we can switch to the high flow nasal cannula just to give the bridge of the nose a rest. But radiology department, this is a critical area in the hospital for all of the imaging that facilitate diagnosis. The most important thing that we look at with radiology is that turnaround time. How quickly are we getting those results to be able to make decision? There are various tiers of that, and I'm going to explain shortly. For virtually all of the modalities that we use, X-rays, ultrasound, CT scan, MRI, our turnaround time is superb. We're doing fantastic. The echocardiogram turnaround, you can see, is a little bit off at 278 minutes, but this does not affect care, right? Because again, echocardiogram in some instances are non-emergent. If a patient comes in at 11 p.m. and the admitting team feels, you know what, I want to do an echo. When I'm working clinically, I sometimes say, yeah, this can wait till the morning. It's not urgent. So that factors into those 278 minutes. But where it is needed for all of those that are urgent, we get them done at that time and we get our report in a timely fashion. Incidental lung nodule, identification and referral. We have shared this program with the board several months ago. It's one of those programs that we just really do excel in. Here at JPS. It's really now a matured program and has been transitioned to pulmonary because it used to be multidisciplinary, but everything about this program has been hardwired, and it's really working well. And we are beating all of the national benchmarks. All what was shared with the board has also been presented at national meetings and has been well received. Trauma and acute care. Of course, JPS is the oldest level 1 trauma center here in Tarrant County and the best. We continue to care for all of our severely injured patients. It's really a program that every single one of us is proud of, that we support. And we are accredited level 1, and we benchmark all of the trauma data to the Trauma Quality Improvement Program. Again, the trauma program is doing very, very well, and you will notice there, again, the hospital-acquired pressure injury, the same thing, the same reason, because we are just looking at all of this more. Another aspect of trauma-related hospital-acquired pressure injuries, there's hardly any patient that has significant trauma without an associated skin injury. Those areas we are identifying as being particularly vulnerable, those areas of skin failure that we have to protect. focused assessed ultrasound in trauma patient, because ultrasound is fast. You really can get ultrasound done on anybody. It's a quick imaging modality that can tell you there is blood in the abdomen, we are going to the OR. This is really ahead of the curve. Even at 31.1%, a lot of trauma programs do not have that. And what they are saying is, even when we perform it under that intense condition, when a patient is just in the trauma bay, we want to be able to capture it and load it into the electronic medical record. A lot of people just do it, they save it on the machine, and does it. But the trauma program is really challenging themselves to go a step further, that we capture this image, but we really want to load it into the EMR. And that's what they are working on. And their goal is to really get to 100% ultimately. This is not a requirement. This is really a self-imposed performance improvement measure, because it is done on all patients and they make clinical decision quickly, as it should. And that is the end of my QAPI presentation. And am I able to the QAPI plan?
Okay. Well, before you go, did anyone else have any questions on any of the information that he's presented? Okay. No? Go on to it. Thank you.
Yes, ma'am. All right, it's that time again, the FY27 QAPI plan. This is our quality assessment and performance improvement plan for the network. There has not been any significant change, but there are notable changes and proposal that is included in the FY27 QAPI plan for your approval. The themes are to update, to make update to reflect the changes that CMS has notified us of, that is part of the QAPI plan since the beginning of this year. One of those is maternal health. Maternal health is required to have its own QAPI plan nestled within the organizational QAPI plan. We have done that. We have also adopted the Joint Commission and National Quality Forum Sentinel event definition. We included that in our QAPI plan. The other is the clinical safety priorities. We are rolling out a new clinical safety and diagnostic excellence committee to really focus on those elements of care like laboratory turnaround time, early patient notification. Did we miss anything in this patient? How can we improve our overall diagnostic excellence? I know I did share some of those with you earlier, but that really is an area where we are beginning a lot of work to further support the clinician to ensure that we are communicating early and to patients regarding their labs, and we are closing all of the loops, and we are learning and further strengthening our systems where needs be. We are also, another key thing that is included in the QAPI plan for FY27 is the Vision Clinical Database for benchmarking. This board approved this tool for us, and it's been very, very useful. We want it to be a source that we'll be using to benchmark ourselves. The significance of this is some of the measures you will see on our quality dashboard is improvement over self. That tells you we do not have enough data to benchmark ourselves to other organizations. Some we have CMS numbers that will tell us that we can benchmark against CMS, but quite often in some of the metrics, CMS only looks at patients with Medicare insurance or Medicare Advantage. They will not look at the JPS connection data because they just don't have access to it. So we always use CMS definition, CMS specification, but we capture all of our patients and not just our Medicare patient. So the Vision Clinical Database is another one, another source of those benchmarking opportunities that we want to bring to bear that will give us that visibility into what other organizations that are similar to us are doing. We have many comparators that we can select from. We can look at academic medical center, we can look at non-academic medical center, but more importantly, we can actually look at safety net hospital and compare ourselves to them to really get a true sense of where we are and where we should be, and really establish benchmark on the basis of that. For the board quality priorities, here is our proposal for your consideration. Again, we will still like to continue prioritizing patient experience And as I mentioned earlier, we are adding the clinical diagnostic safety and excellence. This is really geared towards how do we proactively prevent diagnostic error and delay of diagnosis. And how do we ensure timeliness of results communication and closed-loop follow-up and communication between providers. So this is what that means. And we are proposing it as a board priority. Then disease-specific quality metrics, right, based on our community's prevalence, right? We have the CHNA, and I know this is an initiative and challenge that Dr. Duncan gave to us to really develop metrics that will reflect our community. In addition to looking at CMS metric, leapfrog metrics, what are we seeing in our community, in our patients that come to JPS, and how can we move the needle on those significantly? One of those is blood pressure. We know 41 to 50% of adults in Tarrant County have hypertension. What are we doing about that? So we will get more of those metrics and identify them as priorities. Readmission, we are still recommending to remain a board quality priority, as well as prevention of hospital-acquired infection. And maternal health, as we have always been. Africa program is really undergoing a lot of changes, and we think we should keep Africa program given its strategic importance and being a state mandate. And any additional goal approved by this board for AIP will also be a priority for the quality division.
Is Africa, since we're going to keep it, is it optional? Don't we have to?
We have to do it.
That's not an optional.
It's not an option, the way it's written.
And then with your disease-specific quality metrics, is that something you would work with Dr. Brian Bird at Tarrant County Health to develop diseases he'd like us to track?
Yeah, I mean, where necessary, we definitely will collaborate with the Tarrant County. We do have a robust channel of communication, especially with infection prevention. Our CMO, Dr. Assad, also maintains constant communication with Dr. Bird. And the strongest source of data is really through our community itself. And some of those data we have. They focus on epidemiology and infection, but there are other non-infectious diseases that really ails our community. They will not focus, for example, on stroke or heart failure or hypertension or diabetes. But we have to focus on that because those conditions are eminently manageable and preventable, especially if we optimize blood pressure control. But where opportunities exist, at the departmental level, our infection control team have a robust communication. And I speak to Dr. Bird too occasionally, and some other, the chief epidemiologist will also speak, and my team actually speak to his team as well on areas of commonalities and collaboration. And yes, sir. So this is the Vizient Safety Net 500 that is also nestled in our QAPI plan. This is our proposed selected comparator group from Vizient. You will see our selection is they should be a level 1 trauma and they should have more than 500 beds across the country. So you will see from Grady in Atlanta to LA County in Los Angeles to Metro Health in Cleveland, to Broward in Fort Lauderdale, Jackson Memorial, Parkland. So we have an opportunity to be benchmarking ourselves to this Safety Net 500 group that the data that we'll be getting from Vizient as our fair acuity matched comparator group. This is reflected also in the QAPI plan and is part of the approval that we'll be getting today. So when next we bring our dashboard, quality dashboard, if we may be referencing Vizient as a benchmark that we are referencing, and Safety Net 500, it just means how are we compared to these 10 hospitals that are listed here.
CMI stands for?
Case Mix Index, yes.
Will this allow us to look at, I know we're comparing ourselves to other public hospitals, but will their data allow us to look at other nonprofit hospitals that are similar to us and all of that?
Yes, ma'am.
Okay,
Yes.
okay. Because sometimes I think when we just focus on public hospitals, they're always sicker, but when you overlook at some of the other, we find that they are the same. They're treating
Absolutely.
a lot of the same patient with the same complication.
That is
Okay.
correct.
All right?
Thank you very much. So,
Okay,
Does the plan have to be approved?
Yes.
yes, it's
May
approval.
I just make one suggestion? I don't know, I don't see it, and I apologize, I didn't pick up on this when we were going through this, Dr. Baramosi, but you mentioned the AIP goal, and we are moving to what's called strategic scorecard instead of
Yes,
referring
yes.
to it as the AIP.
Yes, yes, I will make
So if
that.
that's anywhere in this plan, I would just make a suggestion that we change AIP to strategic scorecard.
Thank you. Yes, thank you, ma'am. Yes, we will do that. I think we did, but we'll definitely double check and make all of the corrections.
Okay, thank you.
Thank you.
does anyone else have any questions on the plan? Okay. Then I will entertain a motion with,
I move to approve the strategic plan with the amendment made by Dr. Duncan.
The FY
And
'27
it's
corporate plan.
The quality assessment and performance improvement
Yes.
plan.
Yes.
okay? All right. It's been moved and second. All those in favor signify by saying aye. Aye. And those opposed by nay. Motion passes unanimous. Okay. So, where am I now? Okay. Item B.
Yes.
Okay, now who's present? Oh,
Dr. Webb, are you
you're
prepared to
presenting.
present those?
Yeah, I
Yeah.
can speak to it.
Okay, all right.
There are 12 donation privilege forms that were reviewed in the packet there. There's been reviewed by the departments, credentials committee, the medical executive committee, and then the full medical executive committee has reviewed those also and passed those. I think the House staff office, the staff office did a nice job of putting a nice summary of all the changes. There doesn't seem to be too many major changes as you go through this. They are nicely outlined there with the revisions highlighted. So the medical executive committee brings those to the board to pass those.
I have just one question on those. And they did do a good job of outlining. On some of the numbers, they've reduced some of the numbers of how many procedures that they need to do is pretty low. And I don't know if you have any in there that are high risk. Because to me, if you're doing a high-risk procedure and you reduce it to 5 for over 2 years, I'm not sure we should be doing that. So maybe one of my suggestions would be if there are any categories that have high risk, that would be identified, and those numbers would be maybe looked at differently.
Sure. I think a lot of times when they are lower numbers is when they're not a very popular procedure that's done, rarely done. We can definitely take that back and tell them in the future.
Yeah.
So you want to spell out that specific,
Just hear me say that sometime when I'm looking at the leapfrog information, it'll have information in there that says we are scored low because we don't do enough procedures for that. And so to me, when I'm looking at credentials, that's the same thing I'm looking at. If there are numbers that says you have to do this many and we're not doing it, well, are we competent to continue to do it? And they might be doing them somewhere else that would help in that. But just for us to be aware, for me to be aware that if there are critical procedures, and I don't know how to look at which one would be, if you're only doing one cabbage a year, I wouldn't say we need to do it here, but something, those are the critical ones. Okay. All right, anyone else have any other comments? All right, there is no other comments. I'll entertain a motion for approval of all the delineation of the privileged forms as a group.
we could approve all the delineation of privilege forms as a group.
Okay. All right, it's been moved and second. All those in favor signify by saying aye. Those opposed by nay, motion passed. So we will close our open session at this time, and as far as to go into closed session. And I need about 10 minutes before we do that, okay? Okay. And setting up some
Okay,
standards for
I was
us to
gonna say,
do
I
that,
think
yeah.
that's probably the, take care of the problem. with it.
And kind of, we back open? Okay. We reconvene in open session at 1 minute after 2. There being no further business, we are adjourned.